their questions in
Right.
comment.
Yeah, just maybe put the light.
world to hear this today's fireside chat. I'm Dr. Vasant Nagvekar. I'm an infectious disease consultant at Leelavati Hospital and HN Reliance Hospital from Mumbai. Today, from this prestigious platform of fireside chat, I have the honor and privilege to introduce to you the very distinguished India's Doyen in the global arena of mycobacteriology, Dr. Camilla Rodrigues, ma'am. A trailblazer in the sphere of comprehensive healthcare for patients with TB, Dr. Camilla Rodrigues, Head Department of Microbiology in Hinduja Hospital, Mumbai, is the acclaimed expert in the rapid diagnosis of infectious disease. Tuberculosis, infection control, newer antimicrobial and emerging pathogens has been widely acknowledged. She has to her credit a huge body of work which speaks about the research and academics in TB control diagnostics. She maintains an academic appointment to train MSc and PhD candidates at the University of Mumbai, taking a lead role to establish the section of infectious disease and obtaining recognition for infectious disease as a postdoctoral fellowship by National Board of Examination. Dr. Camilla ma'am has decades of experience running a high-volume TB laboratory, training microbiologists, doctoral candidates, and clinicians. Her research has resulted in more than 311 publications and focused on TB diagnostic tests, including optimization of culture techniques to improve yield, detection of resistance to first-line TB drugs, and molecular assays for rapid detection of XDR-TB, associated genetic mutations, and the resequence TB consortium. A College of American Pathologists auditor, she is the recipient of many awards and honors, and also a board member of ECMED, a very prestigious body across in Europe. Ladies and gentlemen, I feel the privilege to moderate this webinar organized by AMR Declaration Test, a title of Fireside Chat with Dr. Camilla Rodrigues, ma'am, an Indian Doyen in the global arena of mycobacteriology. It's a pleasure, ma'am. It's a pleasure to hear you here in the forum. Welcome, ma'am, to this seminar.
Thanks, Vasant. First of all, there's a disclosure. I'm not a Doyen. I'm just a simple microbiologist. But thank you and Dr. Kapoor for inviting me to this fireside chat on TB. I don't have to tell you that TB is really the oldest pandemic in the world. It actually lurks in every country's backyard. But really, it is a barometer of socio-economic conditions. And though it does affect the rich, it's usually a disease of the disenfranchised and really thrives in poor living conditions and overcrowding. There have been 1 billion deaths in the last 200 years. 1/3 of the world's population is infected with TB. I don't know why any microbiologist is not doing it. It's begging to be done. It's begging to be worked on TB. The deaths we've had is far more than than Ebola, than COVID. And we in India have 22% of the world's burden and is home to 2.7 million TB cases and 1.2 lakh MDR cases. So I think it's time all microbiologists devoted a little bit of their time to TB. I can't hear you, Basant. I can't hear you.
Vasant, your mic is off.
I said, ma'am, that's a huge burden for India, and I think we require, as you said, more and more of Dr. Camilla Rodrigues in India to tackle this problem in India. So, ma'am, your work in TB diagnostics is widely appreciated. How and what made you get interested in focus on tuberculosis? I think we're very much keen to listen to it.
Actually, it's been a long journey. In the early 90s, we were only doing conventional LJs with DST. And I was with Dr. Ajita Mehta, who's been my mentor right through my career. And she had a student from Gujarat who came and said, in Ahmedabad, we're seeing resistance. This was 1990. At the same time, clinicians in our hospital were saying, we can't wait for your LJ reports. Why don't you get onto some automation? So we approached our hospital, and in no time, they were hugely supportive. They gave us a 460 TB. Today, in the early 200s, we got midgets. Today, we have 10 midgets that are running to full capacity. That's almost, 10 into 1,000 is 20,000 cultures of TB being incubated at any point in time. And we service Mumbai's public and private sector. And that's an example of how the private sector can get, close to the public sector and do work for them as well in a harmonious way. In fact, half of our samples that we receive are from the national program. And it's possible because we receive about 150 to 200 samples a day for TB, just for culture and DST, and another 100 for LPA and expert. So it's possible to do it. And I think we all must, it's our responsibility to be committed to this ancient disease.
It's a huge work you are helping not only Mumbai, Maharashtra, but all of India and across the world also, ma'am. Because of your work, many people are able to understand internationally also what's happening. Madam, can you tell us something about the research you have done on this subject and your findings?
Basically, we started off with in the 90s, we chose to focus on TB, and we put one of our research students, Dr. Deepak Almeida, to sort of assess the situation. And we found that, yes, we were having more TB in Mumbai, MDR TB in Mumbai. And to compare it, to sort of really get a grip on what was happening, we compared Mumbai to a village about 2 or 3 hours away from Sakwar village in Mumbai. And there the rates were abysmally low. And compared to Mumbai at that time, we were about 40%. So we knew there was a problem, and we started optimizing culture techniques. We started detecting resistance to first-line drugs. And to be honest, we were the first to describe XDR-TB in India in 2005, and the infamous TDR-TB, which I think indirectly brought about so much change in the TB program in Mumbai, at least. In the early 2000s, our PhD student, Kanchan, Shubhada, she developed a reverse line blot hybridization assay much before we were even aware of the LPA. And we were doing this molecular test in the early 2000s. Kanchan, my other student, developed a RLBH for reverse line blot hybrid for XDR, again, much earlier than we had access to LPA. And then subsequently, in the first NEJM publication that we did on expert, we realized that there was such a huge there's such a huge need for detecting TB, as well as rifampicin resistance. And it's brought on a lot of collaborations in both India and abroad with ICMR, DBT, we're part of the report consortium, with FIND. FIND has hugely supported us, UCSD, NIH, Johns Hopkins, Italy, McGill, Canada, Oxford, with the cryptic group. We've learned a lot. We really learned a lot. And every time I learn more about TB, I think I know less and less. But we've gone on to validate Expert Ultra, TrueNat. TrueNat is our Indian gene expert, Expert LP, Expert XDR, pyrosequencing, and now hopefully targeted NGS will get some sort of place in the WHO endorsement. We're hoping for that. But again, I must tell you, it's not me. It's my students from Chaitali, Viral, Mubin, Preeti, all of them who've done this work and made it possible. But Vasant can't hear you. Yeah.
Madam, not only clinicians from Mumbai, but across India, blessed to have very senior microbiologists like you, who has done so much of research in mycobacteriology and making us understand the pattern of resistance. I don't know what would have happened where TB is the biggest killer disease in India. I think if madam, you are not there, I do not know what would have happened about so much of research of this project going on. Madam, can you tell us something about the evolution of global TB strategies and the infection control practices? What is?
Basically, the world decided in 1994 that it was the DOT strategy to follow. The DOT strategy is, is a government commitment. You have somebody sort of who sort of governs looks at how you're taking your treatment. But it wasn't so successful. So in 2006, the world decided to move to the stop TB strategy. Again, trying to pursue high quality DOTS expansion and enhancement. But finally, in 2014, it's NTB strategy. So currently, we're in the phase of the NTB strategy, where it's integrated patient-centered TB care and prevention. There are clearly bold policies and supportive systems in place, and intensified research and innovation also on vaccination. So the pillars are integrated patient care, screen contacts, look at, find active surveillance, separate patients who have TB safely with good infection control practices. And I think we're definitely getting more bang for the buck with the NTB strategy than we were doing earlier.
Right, ma'am. Thanks for that. Ma'am, do you believe that this COVID-19, what we went through in 2020 till 2022, the COVID-19 pandemic, did it really have an effect on the TB control measures in Mumbai and India and across the world?
It absolutely did. COVID had a devastating impact on TB services. We lost 10 years of progress. And the global targets were clearly derailed. In fact, globally, 10 million people were either not diagnosed or reported by 2021. In our country, we found for the first time in more than a decade, we had TB deaths, TB incidents in MDR, TB increased in 2021, and the incidence was actually quite frightening. So we feel that definitely India being listed as one of the top 3 countries, we're going to see this sort of boomerang back on us, and the reduction in the newly detected TB cases will lead to long-term increase in TB incidence, morbidity, mortality. But let's not be depressed. I think whilst COVID derailed our goals, let's not blame it any longer and move on quickly. I think there is renewed focus across the world on serving the vulnerable, and that has become a huge area that's pointing the way forward for the future. And I think serving the vulnerable for TB is an important point. And the pandemic dividends, as I see, gap in delay in diagnostics. I mean, access to PCR at point of care suddenly became a reality thanks to COVID. It wouldn't have. There was a lot of political will to get COVID organized. And with COVID, I think we need pathways to leverage and harness this capacity for TB. We need to leverage how they were doing, collecting samples, lab testing, returning to the patient. It was done within hours and days. We need to take this and extend it to TB. We have this COVID example that it's possible for TB.
Definitely, COVID did push us 10 years back, and it was the darker side. But I think the brighter side is with the rapid diagnostics which are coming up. I think that's going to, compensate for that and possibly help to control the tuberculosis. And what diagnostics issues do you see in the TB control in the current situation?
Just imagine today we have molecular techniques at our disposal, and yet 61% of bacteriologically confirmed TB cases are just 61% are tested for DIF resistance. Effective control really requires rapid diagnosis, initiation of appropriate treatment, because accurate diagnosis, you all know, has the potential to be the cornerstone in TB control. The faster we diagnose, the quicker we put our patients on effective treatment, we will interrupt transmission. And for years, we were relying on smear and culture, and that was the Achilles heel. I always say that molecular diagnosis has been the time to usher in this new era. We've really done it quickly with quick endorsements, and the landscape of the TB diagnostics has changed hugely. There was, I think, Vladimir Lenin who said, there are decades when nothing happens and weeks when decades happen. And today, if you look at the TB landscape, every month there's some new diagnostics happening. It's so exciting. So from expert, G4, TrueNat, Ultra, LPA, we were really able to do so much. And I think, we moved on a lot, and we need to quickly cash in on molecular technology, because that is really here to stay, because it's replacing months of waiting, months of loss to follow-up. So I think it's molecular. And I think newer diagnostics, the ones that are coming, in the pipeline, say last year, tongue swabs, etc., still have yet to reach scale. And we're talking of, biomarkers with transcript RNA signatures, metagenomics, all that is still in the pipeline. It will happen in the next 4 to 5 years.
Nice to hear that with this newer diagnostics, molecular diagnostics coming up, and rapidly diagnosing MDR, XDR, TB, I think things will be getting better. And exactly the next, what I wanted to ask ma'am is, have the molecular tests been really the game changers they promised to be? And what are the limitations of this near point of control, the molecular POC, molecular tests?
There's certainly been transformative, no question about it. I mean, expert has really been transformative in diagnosis of TB. And not only that, the success of expert has sort of catapulted considerable interest in these new technologies. And that's been really wonderful for us to see. What happened is that, the problems with experts seem to be, there was a diagnostic and treatment gap, certainly reduced the time to treatment, certainly increased bacteriological confirmation, but when there was a study done in South Africa, which actually showed there was not much increase in getting patients on treatment. Maybe they were empirically put on it. And maybe there was also not much impact on mortality, but I believe they've been completely transformative, really expert ultra. The limitations perhaps of expert have been that INH monoresistance is not picked up in RIF sensitive, and we need to quickly tackle that because it's, INH is really a prodrug that predates RIF resistance. This has been seen across all lineages, across all geographical locations and over time. And remember, INH monoresistance, it's not being picked up by rifampicin by the expert, results in failure in 11%, relapse in 10%, and can actually predispose to MDR in about 8% of cases. The other thing I think is we actually have to pick up fluoroquinolone resistance, at least in our country, upfront, especially in India. So if you ask, yeah, tell me.
Sorry.
If you ask me what were the limitations, it was just not near enough. I think expert, and they have to be much nearer the patient. We have to have decentralized care. We have to be close to our patients in villages. They have to be affordable. So they're not really point of care. We need to move to point of care. We need to detect TB not in sputum, in tongue swabs, in biomarkers, in sweat, saliva, etc. etc. There's a urinary lamp, second and third generation, that is being marketed by Fujifilm, not for HIV patients, for normal patients, for non-HIV patients. And that is a good, exciting way to, again, there's another, and India is actually looking at these innovations in a big way. There's computer-aided detection with AI in place. And really, believe me, it is a hugely promising advance because AI in radiology can get to the community. You don't need to have a radiologist there. The AI will tell you whether this is normal or abnormal and leave the abnormal for the radiologist to pick up. So at least, we're slowly getting there. And I think we'll overcome these limitations of point of care soon.
Ma'am, about all these, especially the scary part is about 10 to 15% INH monoresistance, which is revealing, and also the fluoroquinolone resistance. And exactly to this same thing, what you spoke, ma'am, I came across an article, Swimming Against the Stream. Now, why did stream 2 data, which is applicable other countries, cannot be applied to MDR cases in India? Do you have any comments on this?
Actually, Zari recently published a small letter in Lung India. And basically, stream 2, as you know, is 4 regimes. One is standard 18-month MDR. Regimen B, C, and D all rely on giving fluoroquinolones. And basically, these are short-term oral regimen. I think C is not. C is possibly, one of them has an aminoglycoside, but it's basically shortening the regimen to 40 weeks. But the initial supplement is going to be with high-dose INH. Now, we did a study where in 2021, we analyzed our data for 2 years, and we found that at our tertiary care center, albeit it with a tertiary care referral bias, we had an MDR cohort of about 26%. But what was even worse was that 68% of our MDR patients, 68% were fluoroquinolone resistance. Not only were the fluoroquinolone resistance low level, they were, I think it was, I can't remember the day, but it was 75%, I think, of the fluoroquinolone resistance were high levels. So you couldn't even give moxi. Now, if you look at the newer regimens being thought of or being discussed at the global arena, a lot of them are dealing with moxi. And the stream 2, like I said, 3 of them all had moxi in it, all had high dose INH in it. We can't give it because even CAT-G was almost, I think, 85% of our MDR patients had CAT-G, which means high dose INH also goes out of the window. Now, if you look at the latest regimens, the BPAL is okay for us in India, but BPAL-M, no, because BPAL-M has moxifloxacin. 2 regimens, I think, that which will have some sort of future for us would be BPAL and BPAL-C, that is bedaquiline, pretomanid, linezolid, and clofazimine, but not moxifloxacin. But again, this data, Vasant, is out of my hospital in Mumbai, which is a hotspot. Perhaps it doesn't translate across the country. I know in Chennai, the rates are far lower. So you have to know the local epidemiology really, really well before you can sort of, say that this is not going to work in your patch of the world.
So I think, ma'am, that's very scary that what we were using, like, we had hardly any choices. And we were banking upon, if there's a low level resistance to moxifloxacin, possibly using 600 milligram of moxifloxacin would serve our purpose. But now listening to this, ma'am, from you that, it's quite scary that 67% having that fluoroquinolone resistance. And also, using 10 milligram per kg of INH high dose as soon as that also is not available, not available. So, we are 2 arms cut. Already we are struggling with this making a regimen, and we have these 2 important things going away. It's really being most scary. Ma'am, can you enumerate, I'm sorry to push you, but can you enumerate the challenges of this drug-resistant TB and gaps that need to be closed?
That's all order, Vasan. The problems confronting TB today, as we all know, is decades of neglect, just like in antimicrobials, which is fostered by the misconception that drugs had beaten the blood. Again, DRTB reverses is going to threaten to derail gains in global TB control, because it is a global public health crisis that despite all the advances we've done, only 1 in 3 patients are put on treatment, and of these, only 60% are treated successfully. I mean, how sad is that? And the specter of DRTB has haunted us ever since the beginning of the anti-TB era. And like we say, DRTB is unforgiving. It's a soul-destroying disease. It ravages your lungs. It kills your spirit because you don't have any friends. Your family is also looking at you. This guy's got TB. And the worst is the adverse drug reactions are unbearable and really untenable. So the challenges are use of regimes with limited efficacy, significant toxicity and high pill burden. We used to, why don't you just add this? Why don't you just add this? Or continue on first line, add another 3, 4. We have to think carefully. We have to really weigh out that the patient is going to get a huge pill burden, and that's unfair. And I believe standardized treatment without DST in today's world is not fair to our patients. I think it's unethical. Giving non-quality assured medications and drug stockouts again is not acceptable, and lack of access to the newer and repurposed drugs, the NRD as we call them, does sometimes happen. Yeah.
You wanted to say something?
No, go ahead. I couldn't hear you.
I said, ma'am, we're already struggling with the multi-drug resistant TB. But madam, how would you address clinical failures in drug sensitive TB and the role of therapeutic drug monitoring, which is actually not really practiced, or maybe it's not available across. We are lucky to have Induja at our website where we can use this therapeutic drug monitoring. But the MDR TB to understood, even drug sensitive TB, we have seen many times we are struggling with these patients, and that is any your insights on this drug sensitive TB and the TB.
Yeah, I think clinical deterioration, despite having a report that says the patient is drug susceptible, is usually due to inadequate dosing, not for the weight, using fixed drug combination, which may not be bearing out the weight, the dose. I think poor adherence is not so often. I think patients are now complying better. Paradoxical response is something we have to keep in mind. And suboptimal drug penetration at extrapulmonary sites is again another issue. Poor absorption. We had a boy the other day who was not responding. Then the clinician was refusing to accept this was drug sensitive TB. But it was just that he had a malabsorption syndrome, and that was brought to light by the role of TDM, that is therapeutic drug monitoring. Because what we found, it's not done by me, but by our biochem department, we found that fixed drug combinations may fail, especially in low acetylator phenotypes. And 2/3 of us Indians have the genotype for being slow acetylators of INH. And in the presence of prolonged exposure to INH, there's reduced bioavailability to rifampicin. So when we find that, we ask the patients to split their doses. You take INH in the morning, wait, and then take rifampicin at lunchtime. Don't mix them together, because INH and rifampicin are actually antagonistic to each other. We had done a study, or rather biochemistry had done a study where they found that, about almost, I think 50% odd patients were in the subtherapeutic range, but some of them responded. So when we wondered why they responded, we looked at their AUC to MIC ratios and found when it achieved the magical 271, the patient showed a better response. But the ones who didn't achieve the AUC to MIC ratio, they had more relapse, more failure, and more resistance. So that's what we need to remember. So who would definitely need a TDM? I think it would be critically ill, TBM, TB osteomyelitis, patients on HIV medication, diabetes, hepatic and renal disease, and when you suspect drug-drug interactions. The reasons why we're not doing TDM, I think, is lack of knowledge, funding. I think it's cost issue, and lack of guidelines. Strangely, they're not great guidelines across the world for when to do TDM. Implementation again is complicated and overburdening the health systems.
The majority of the pills presently, what is available are these fixed drug combinations, and that's a concern. But yes, those patients, I think, who are drug sensitive TB and who are not clinically doing well, possibly I think we should look at the TDM, or maybe I think, as you exactly said, we should split the medication separately, and that might give a better clinical response.
Yeah.
So, ma'am, just coming to the next thing, do you think India is ready for next generation sequencing? What is your personal experience in utilizing the next generation?
I mean, countries like UK who don't have much of TB, New York State, all have employed whole genome sequencing as standard of care. They don't do phenotypic DSTs. They don't use midgets for DST. But in a way, I think for us, if you were to ask me, should India have NGS? I don't think we don't have the money and the bandwidth across the country to start it. But I think patients who are pre-XDR, and that is detectable today by LPA, it's detectable by XDR TB. Once you have a pre-XDR, I think you cannot afford to get it wrong. This patient is just on a lifeline of few drugs. You've got to get it right. So these patients, I think, must have some sort of next-gen sequencing, whether it is whole genome or whether it is targeted NGS. We must try and get them their cultures out, or if you have the bandwidth to do it directly from samples, do it directly from samples when we're talking about targeted NGS. And it's also, NGS has a role in looking at genetic relatedness. So we had done a study as part of the cryptic study, which we did, where we found that there was 3 lineages of Beijing strain in Mumbai that were not only pre-XDR, but they were so fit that they were transmitting much, much more than a normal DSTB. So that, identifying a clonal outbreak and quickly stepping in to sort of curtail it, that can come out of these great technologies. But again, the good news is that there's a global alignment. Everybody is moving towards a common goal, and the WHO has these wonderful, really believe me, they are wonderful mutation catalogs, because they have curated the data so well to correlate mutations with phenotypic DST. The version 1 is out. Now we're eagerly awaiting the version 2. And the robust bioinformatics has allowed it to happen. I think what prevents us is sequencing challenges, high cost, lack of skilled faculty, limited access to all the analytics. But once it becomes plug and play, believe me, NGS will be the norm. And automation platforms with good quality control in the pipeline will allow. It will take about 2 or 3 years. We're trying to get into projects on CRISPR, which will make it easier, but I think that's where we need to focus on.
Clear that I think we have to move as the world is moving from phenotypic to the next generation sequencing.
Absolutely.
I think then only we'll be able to address our issues just like the other world, and our problem is huge compared to the whole rest of the world. But I just wanted to know from you, this targeted next generation sequencing versus the whole genome sequencing. Also, ma'am, would like to know from the split sequencing which was there, which was a point of care test. Novel, we thought this would help us to guide us what treatment or what drugs can be used quickly in our treatment portfolio.
Just to put it simply, whole genome sequencing is when you take the whole genome and you sequence every bit of it. Targeted, but whole genome sequencing as of today cannot directly be done from samples easily. You need a culture. So if we're talking time, the turnaround time is at least 10 days to about 3 weeks by the time you grow out your bug, and then you do a whole genome sequencing on it. So you lose time there, but no question. It is a comprehensive solution and it detects rare mutations, etc. targeted sequencing can be done directly from the patient's sputum sample. We've just finished a project on with Unitaid that was governed by FIND of 400 odd DRTB cases that were proven by expert. And in 2 days, we could give you results on 14 drugs, sometimes 14, 15 drugs, and it was easily done. But again, it's expensive. And the best part of targeted NGS was that it had really simple bioinformatics. You don't need a smart bioinformatician to sort of read the data. It was all done on the iCloud. But it gives less information, that whole genome. But to a clinician like you, Vasant, you only want, tell me my drug is going to be red or green. That much we can tell you. And SpitSeq, as you asked, SpitSeq is a technology that was actually developed by MedGenome in Bangalore. It's a made in India product. That's good. They use, they enrich the MTB with the aim of directly doing it from samples. We worked with them in 2018, and we actually had a publication with them where we used in-house styling it's their proprietary, they've got a patent on it, I think. They use in-house styling bait, which will capture all the MTB from the samples. So they're trying to do whole genome sequencing directly from samples. It didn't work for smear negative, which is also a problem. But it's something to look at. And currently, we had to actually send it to Bangalore, so there was a loss in time and stuff.
Ma'am, I think for a clinician like me, how you said, the next generation sequencing is what is required for me. And maybe,
Yes.
ma'am, for epidemiological point of view, I think whole genome sequencing is also very, very important, which even after the culture, because you have to know what's happening in the community. Otherwise, apart from the
Absolutely, you said it. You absolutely said it. So actually, whole genome sequencing is going to become a must for national surveillance. And India is actually, we are trying to utilize our capacity, which we set up for COVID sequencing. Now, DBT is setting up, ICMR is setting up, looking at whole genome sequences. So we are sending them data. We're starting hopefully in August, sending them data from our sites where they will use the sequencers and bring out some India-centric data. So is NIRT for that matter. So, the good national TB labs are aware of this problem, and we will get some data and surveillance hopefully soon.
Also from this molecular part, I think the basics again, we have the gene expert, then we have the ultra gene expert, and when we have the ultra gene XDI also.
Yeah.
And also when you have the ultra gene expert, we have this sometimes reported as very low detectable in the ultra gene expert. So sometimes we also confuse very, very low. So, what is the significance of that? And also, when because of Hinduja and you, and I think I know Kanchan also, because of TB pyrosequencing, we had at least 3 patients whom all your expert, everything cultures been negative. In the CSF, the pyrosequencing really helped us. Can you put some light on this about the ultra gene expert and the ultra gene expert XDR, as well as the pyrosequencing?
See, ultra, when Sheffield actually developed Gene Expert, they realized that their limit, LOD, it's called the limit of detection, or the analytical sensitivity, was about 112 copies per mil. And they realized that in HIV patients, in paucibacillary states, especially like in EPTB or in children who have TB, where they're not able to cough out, it was failing. It was not doing so well, not that it was failing, but it was not doing really. So they developed the ultra, and the ultra is better than the expert because its sensitivity is, in the sense, in expert, the original expert, we were detecting the RPO-B gene for detection of TB and also for rifampicin resistance. But in ultra, they moved on to insertion sequences, IS6110, IS1081, which is repeated 16 and 6 times respectively. So you're already starting with so many more targets than you would for Gene Expert. So your sensitivity is clearly going to go up, no question about that. But with good things in life come bad things as well. So ultra is really helpful, especially for paucibacillary states. But in patients who've had previous history of TB, you may get a trace positive, which is difficult to interpret. So trace ultra that has, in a patient who has TB, I would say, wait for culture. whereas it's really great for possibacillary states such as, like we've said, EPTB, even in TB meningitis. I think the Ugandan group, Nathan, had done a good study where he showed that in TBM in HIV patients, he got almost 95 or 98% sensitivity. How great is that? With us, it's been about 72% the ultra sensitivity in proven TB meningitis. But still we lack, and in Mumbai, we really get desperate. So we have pyrosequencing that again came to us on a NIH grant. And this relies on pyrophosphate detection. And we did a study with Umang where we showed that in 100 patients that were defined as per the classification of TBM, definite, probable, and possible. In the definite cases, we got 98% sensitivity with ultra. So with the pyrosequencing, we're quite happy with that. But I don't think it's still perfect. We need to get better than that.
Thanks for that. And I think pyrosequencing definitely has helped our patients, and it is definitely for especially the CSF and urinary, it's been really very, very helpful for detecting those people. Now, how hopeful you think we can be to eradicate TB, if at all, and your insights on this plan?
I think as a physician in our country, we have to be hopeful. We can't give up and say, oh, it's not going to be eradicated. We have to believe it will be eradicated, and then it will happen, because TB is the perfect expression of an imperfect civilization. It is for millennia, it's been like that. And we've been battling this for 70,000 years, and it's sort of been with us. And it drives a paradigm of a near perfect host-pathogen relationship. But it is preventable and curable. I think every 3 sentences, I must say this, it is preventable and curable. And public-private partnerships can be strengthened and utilized, but again, these are complex systems and they rely on relationships between various groups and different agendas. So if I were to say, how do we eradicate TB, I would say 5 points. One is early detection is a key strategy. You have to get to the last mile where the last patient is. You can't sit in a middle, in a 2-tier city and say, oh, I have an expert. You have to get to the patient in the village. You have to create awareness. Whether Amitabh Bachchan does it on TV and on platforms such as TV, I think those are important. You have to, urgent actions need to be taken for improving our healthcare infrastructure, no question. Early detection, we're getting there. Robust pipelines are existing. And India last year did a 26 standards of care in India that were diagnostics, treatment, adherence, counseling, the works. Thirdly, it is funding. I think TB receives less funding than HIV or malaria globally. And even though TB kills much more patients than both of these together, the WHO actually estimates that there is a $3.5 billion shortfall for TB. We have to put pressure and get the world to commit to TB. And 4th point is, I don't know whether it's the right way, because I think we can just about coping with active TB, but TB has to be treated the same way in poor countries as it is in the rich ones. You have to go after latent TB. You have to go after contacts. We're starting to do that. Look at America. When it had the problem in 1990, they eradicated it in 2 years. Similarly, they did the same in the 1950s with Alaska. And the 5th point is, I think, better nutrition, better housing, better sanitation is the absolute basis for eradicating TB. In 1991, the US passed something known as the TB windows. TB windows was a tenement law that if you had a tenement or a slum house, you had to have a big, huge window. That had to be open. And with that better ventilation, they really brought down the TB incidence in New York and in cities where there were tenements, just by fresh air and improving the environment. And of course, we need to improve our undernourishment, sort of eliminate the stigma attached to TB, and we can hope for a TB-free future.
Thanks, ma'am, for that very, very positive approach to eradicate TB from India. And it's always it's been a pleasure, and it can go on and on and on. I mean, it's always a pleasure listening to you about any subject in microbiology, especially what TB has been very close to your heart. Ma'am, and in the end, I would like to ask you, and I think we listened from everything, right, from basics to the diagnostics, molecular, and a lot of positivity we heard from you about how we can be able to tackle tuberculosis in India and how can we be able to eradicate, and also the newer diagnostics molecular tests which are going to be available soon, which will help all the clinicians across India. And my last message to the newly budding microbiologists, how what is your message for this new microbiologists who are just budding and getting into the clinical area?
I think we've just emerged from a pandemic, and we emerged victorious because of knowledge of the genome. And this was done by microbiologists. We would not have been able to come out of the pandemic without a vaccine. The vaccine was possible because we knew about the genome. We know DRTB is lab diagnosis, and we are already, as microbiologists, we're performing rapid DSTs to prove it. And yet microbiology is one field where there's not enough just to test. You have to learn to interpret every critical concentration. You have to learn to interpret every mutation, because molecular medicine has opened those vistas. We are standing at the threshold of precision therapy, and nothing more than TB is precision. You have a DST, you can actually pick up the individualized therapy you want to give your patients. They will tell us whether this mutation can be treated with a higher dose of the drug or not. Don't give the drug. And the best part is today we can associate it with clinical outcome, and that is really what we're all here for. And microbiology is making that difference, directly applying to patient treatment and their outcomes. And just in keeping with the basic tenets of diagnostic stewardship, deals with the right test, the right patient at the right time. Once you have the microbiology, remember microbiologists, you have to have microbiology tests. Only then you are poised to conform to antimicrobial stewardship with the right interpretation of the test to give the right drug dose and duration. So if I can just end with, it will be ours, or microbiology is really an exact science. So follow the facts, be detail oriented. Don't just look at it like that. Get clinical, move out of the cozy confines of the lab and get involved in patient care, because whether you do it by design or in an advisory capacity is up to you. And most important, get needed. You should be needed. I can't tell you the importance of that. Extra work and extra responsibility does take time, but it's so worth it at the end of the day.
And thank you so much for your message for the new microbiologists, and I think we'll have more and more Dr. Camilla Rodrigues for
enough. They're sick of me.
Can eradicate tuberculosis. Madam, it has been a great pleasure to interacting with you and in the fireside chat for more than 45 minutes. Madam, just stay on whether we have some questions from the audience and.
Sure.
Kapoor sir, you any comments from you, sir?
Thank you, Camilla ma'am, for your highly valuable comments, your lifetime experience. What are the challenges? I just ask one question. I'm very keen to know what challenges you faced in your career and how you overcame it. Because when young generation of microbiologists, infectious disease physicians, and medical community in India look at Camilla Rodrigues, I'm sure it's easy to say Dr. Camilla is a big doctor, but I'm sure the journey hasn't been that easy for you in a professional way, because you wouldn't have achieved what you have achieved without a very difficult journey. And would you please be kind enough to tell us what were those difficulties and how you overcame those difficulties?
To be honest, Dr. Kapoor, I feel it was support of the clinicians. I honestly feel at every forum, when you interact with them and they realize they're getting something a little bit out of you, they start, coming back and saying, why don't you do this? Why don't we do that? Why don't we do that? Not why don't you do that? So it's a partnership that they're all involved in. I mean, even if you look at critical care, it's every one of our critical care physicians has been involved with us and is all the time getting back to us. Why don't we do this? Camilla, why don't we do that? Why don't we? So I think it is support of the clinicians that helps the microbiologists. If they sit around and say, "Arey, kuch farak nahi padta hai, kya wo aise hi hai, waisa hai, ye falana hospital mein acha microbiologist," I keep saying never. You have to nurture your microbiologists. They are really dying to be nurtured. I really believe so. So it is physician based. If the physician trusts you and believes in you, automatically the microbiologist will be better.
Thank you, ma'am.
Well, today's webinar, the people across the world listening to you, right, from USA, Malaysia, and other countries, they have been registered very, very early. The moment they came to know that Camilla ma'am is today going to be on the.
I don't think it's me. I think it's the topic.
We have got few questions from the audience on the YouTube. I'm just going through the questions. A lot of questions on the YouTube. And ma'am, can I read out a few questions?
Sure. Go ahead.
I think you answered already. Ravi Teja asked, ma'am, interpretation of the expert MTB ultra trace call in pulmonary and extrapulmonary samples. And in both scenario, if we can't repeat a sample, what to do? Interpretation of expert MTB ultra trace in pulmonary, extrapulmonary samples.
The WHO actually, earlier what we were doing, if we got a trace in a patient who had previous history of TB, we were repeating it. But the WHO last year has said, no, don't repeat it. You wait for culture. If you're not suspecting TB in a patient, you must have a good pre-test prevalence for doing ultra in patients who've had TB in the past. From extrapulmonary patient samples, I think you have to believe it's a true positive. Again, it's high endemicity TB country or a low endemicity TB country. If you have a high, like we are in high end, no question about it. So with us, I would look at it this way: EPTB, HIV TB, and pediatric TB, believe the ultra trace report. In a respiratory case, I would wait for culture.
Yeah, thank you, man. Now, this interesting question we all get called every day. The RIF resistance indeterminate. What does that exactly convey? How do you explain that to the clinician, the indeterminate RIF resistance?
See, it was like this. When the first gene expert came, G4 as it's called, we found that in patients who had very low loads of MTB, there was a chance that about 40%, 30 to 40% may be false resistance, and it was RIF resistance detected. If you had very low load and RIF resistance detected, in 40% of patients, we actually proved by sequencing that these were actually sensitive because we couldn't find anything in the RPO beta region. So what Cepheid did, they said rather than confuse the clinicians by giving because this was being formed due to an unstable hybrid that was giving a false resistance in low loads. So when you get trace of very low loads, they just said, look, we don't know. This is indeterminate, you wait. We're telling you it's TB, but and again, the limit of detection for rifampicin resistance in ultra is 140 copies. Whereas for TB detection, it's 12. So you're going to have a disparate response.
Yeah, because many people get confused this indeterminate to intermediate.
No, again, we looked at our data and we found that in ultra patients who had given very low load or trace with RIF indeterminate, about 43 or 44% of them on culture was sensitive. So you don't have to think that it's because the first reaction is, oh, indeterminate must be resistant. It's not. It is not resistant. So don't be worried that, oh gosh, I must start this patient on, it means drug resistance. You have to wait and do a DST if possible, or sequence with pyrosequencing or targeted.
And the next question is, ma'am, can you explain again why we have to split INH and rifampicin to morning and afternoon?
See, in patients who are slow acetylators, we have two types of metabolism for post-metabolism of isoniazid. You have people who quickly metabolize it. So INH, those are the fast acetylators. The slow take a much longer time to metabolize INH. And INH and RIF, the two mainstay drugs, are actually antagonistic to each other. So if you have INH for a longer time in a slow acetylator, you will antagonize RIF for longer. So don't do that. Just separate them. So by then, the level of INH decreases. And if you split it, we found much better results in the levels when we did that. So we started giving our patients, separating INH and RIP. And they were the ones who were not able to attain good TDM. When we separated the doses are fully at the same dose, are now attaining good levels.
So when we should we give INH in the morning and rifampicin lunchtime? Is that okay?
Yeah. If it is a slow acetylate, you have to prove that there is an NAD phenotype in that. But he's a slow acetylate. That's when it's best done. But we do that practically most often, especially when you're like Vasant said, when you're having problems, the patient is not doing well. Most often we get away. And then we say, oh, why do we do this TDM? Is it really required? I don't think my patient is doing fine and his level was low. That is because the AUC to MIC was achievable in a subtherapeutic range of TDM.
Over to you, Vasant.
Yes, ma'am. Thanks. I think we are already close to 1 hour, and I think I don't want to drag on, ma'am. I know we can just keep on going for hours together because it's such an interesting subject and a problem, and it's a challenge, and I would say it's everybody's problem. It's not only one. It is just like infection control practices. It is, I think, tuberculosis is everybody's problem. So I think individually at every level we should see that we use the utmost diagnostics what is available in your city or your country and utilize it to the maximum to have the correct antimicrobial drugs susceptibility and the diagnostic ultra-gene or whatever pyrosequencing or ultra XDR what is available. And I think the future is going to be, as ma'am said, next generation sequencing. And we have learned a lot, and I think it was a great privilege for me to be, on this side of the table. And thank you so much.
Thank you, Dr. Gopan. Thank you. Thanks so much. Good night.
Thank you, ma'am.
Thanks.
Good night.